Now, if you're looking at treatment goals, again, big key is to induce remission. Someone comes in with symptoms, the sooner you get them treated, in remission, the better they're going to be long-term in terms of not developing complications. Their quality of life certainly is going to be a lot better. You want to, also in terms of treatment, you got to look at the medications you're using and explain to some of them, to people, that some of these have potential side effects, but you have to look at the side effects, risks of the side effects of the medication versus the risk of the disease. Obviously, the big key is even one of the quality of care issues that people who treat a lot of inflammatory bowel disease is get rid of steroids. They are not good. If you were to look at two of the most significant factors in terms of morbidity, illness, or mortality with inflammatory bowel disease, one is steroids, two is narcotics. So we don't like patients on steroids. We know they are and often can be a necessity at some point in terms of getting their disease into remission. Long term, they are not effective in keeping one in remission. Again, now treatment. Now there are a lot of treatments. People take over-the-counter medications, prescription medications, and treatment can involve surgery and can be very appropriate and very effective. And then there is a big rise recently in these complementary alternative medicines. And I'm sure, well, many of my patients will come in and say, what do you think about this? And I say, why are you thinking about that? You know, and they've read it somewhere, they've read it on a site, and so there is maybe a role for some. Anyway, the typical treatment of Crohn's disease is what's called step-up therapy. It's pyramid. You start with the least potent medicines that are able to treat, now I see you a little look there, but to treat starting bottom up. Start with the medicines that have potentially the least side effects for the mild to moderate. And as a patient has symptoms become more severe, introduce steroids, some of these other medicines, cyclosporin, which is an immunomodulator, azathioprine, infliximab, Humira, and ultimately surgery for the moderate to severe. And this is the way we've always treated Crohn's disease. Here's just another way of looking at it. Again, you start from the mildest form of drug to treat patients first, and then you move up in patients who are not responding. We've learned a lot from the rheumatologists. The rheumatologists started out this way. They start off with aspirin therapy, they start with then maybe gold therapy, and they slowly increase and they add methotrexate, then biologics. Well, the problem is it's a lot easier to follow a person who has rheumatoid arthritis because you can see the hand suddenly not looking so good. You can follow x-rays that you can look at joint spaces, you can look at inflammation. They have certain scales that are very well accepted that they can show, so they can actually demonstrate a very clear progression of the disease. And what they're realizing is they can't do it the way they've been doing. If they treat this rheumatoid arthritis with this sort of step-up therapy, they're going to have patients all looking like this, and by the time that they use a potent medicine, it's not going to be effective. So they're learning, we are learning from them. That, you know, maybe this slow progressive is not going to be the same, is going to be the same way we're going to see it. The problem is we don't have good measures and objective evidence of being able to, you can't just do a colon every 2 weeks every time you add or subtract or change a medicine. So we are somewhat at a loss in terms of a standard scale, etc., to assess our patients. But we have learned, and we're realizing that, you know, maybe we should maybe attack this from a top-down therapy, get the disease under control more quickly, and then maybe back off and use less medicine, less potent medicine. But anyway, if you look at these medicine categories, and I'm taking this actually from a Crohn's and Colitis Foundation talk I gave, just because it looks, I mean, it's easy to sort of follow. I mean, one is over-the-counter medicines. Antibiotics, do they have a role? Aminosalicylates, which include things such as, we all know, pentasa, acicol, steroids, immunomodulators, azathioprine, and biologics. Everybody still awake? We've only just begun. Anyway, I mean, over-the-counter are pretty obvious. We take them for symptom relief. They're not going to cure the disease. They're not going to put it in remission. But, people take anti-diarrheal medicines. People actually with colonic disease and rectal disease actually can present with constipation. They feel like they have to move their bowels. They have something called tenesmus. It's like a constant urge to move, but not much happens. So people are wanting things like laxatives, pain relievers, which in general I don't use. Because if there's a problem and there's an issue, we're going to treat the problem and take care of it. And I don't have anyone on chronic narcotics in my practice. And again, it's really important for someone who has inflammatory bowel disease, who may be on immunosuppressant medicine, even steroids, that they really need to talk to their physician. They really have to have a very good rapport with their doctor and really feel comfortable with their doctor. They have to really feel like they're getting what they need from them, and in turn, because not being able to be truthful, to be honest, not only in terms of taking medicine, adherence, etc., is only going to not going to benefit the patient. It's not going to do well in the future. Again, antibiotics. Well, there's something called pouchitis, which it happens in ulcerative colitis when you take the colon out. I really don't want to go into that too much, but there's some effect in terms of treating those people. These fistulas that I talked about, there have been some efficacy in using antibiotics. Problem is, like anything, like with pouchitis, where you may treat some of these patients with antibiotics long term, and you've got concerns about resistance to bacteria. The question is, are there going to be flares, other side effects that are going to occur with some of these medications? And some of the antibiotics I'm talking about, ciprofloxacin has been used, metronidazole has been used in terms of perineal disease. It also has been used post-operatively in preventing recurrent disease, but only if the problem is with metronidazole, over long term you develop what's called a peripheral neuropathy, sort of numbness, tingling of your feet and hands, and most people don't obviously tolerate that. Rifaximin, which has been getting a lot of press for a lot of different diseases. One study recently came out looking at rifaximin in active Crohn's disease, and it looks like some of the initial studies there may be some benefit. But that's really about it for antibiotics. I'm going to pass on that. So in general, antibiotics, just like for most viral infections in the world, don't do a lot in terms of disease in Crohn's, Crohn's involving the lumen. So if you have perineal disease and some of the other potential complications, they may be effective. Even in these fistulas in the perineal area, there haven't been any good controlled trials. Most of them have been either anecdotal studies or non-controlled. Again, I said that with post-operative recurrence, and I said, one of the concerns for having surgery with Crohn's is that there's an increased risk of recurrent disease at the anastomosis, and one of the keys is what can we do to prevent that? Well, metronidazole has been found to be effective, but only for about 3 months. And again, toxicity we're talking about, particularly with metronidazole, in terms of the neuropathy, ciprofloxacin in terms of tendon rupture, and also in use in younger kids because of that. So now we're getting to sort of the first line medications that we typically use for treating like mild to moderate Crohn's disease. And these are called aminosalicylates. Orally, the first drug that really was available was sulfasalazine. And sulfasalazine actually was found in terms of being beneficial for inflammatory bowel disease because it was used to treat rheumatoid arthritis. And they found that people with rheumatoid arthritis who were treated with sulfasalazine, who also had ulcerative colitis or Crohn's, primarily ulcerative colitis, got a marked improvement in their symptoms. We don't use sulfasalazine as much anymore because the active component is bound to sulfapyridine, which is an antibiotic, which is there's a bond which is cleaved by the bacteria in the colon. The sulfapyridine antibiotic gets absorbed, and you can get rashes, fevers, and although it's a fairly cheap medication, and those who might not be able to afford some of the other mesalamine products, it's not used as much. Now, those people who tend to have arthralgias sometimes benefit from use of this. But we've gone on to use a group of medicines called mesalamines, which I'm sure many have heard: Asacol, Pentasa. Dipentum is not much used anymore. It actually is two active aminosalicylates bound together, and the idea is when it gets into the colon, the bacteria break it. Now you've got two, sort of like two for the price of one, so to speak. Well, the problem is that it causes 30% of people get the secretory diarrhea from it. So side effect was a little bit more than was effective, so it really isn't much used anymore. Lialda is a medication that has a very unique multi-matrix. It's once a day, which is an improvement compared to, for example, balsalazide, which is 3 times a day, Pentasa, which can be up to 4 times a day, and Asacol up to 3. Although, if people are in remission now, one of the acceptable things to do is you can actually take sort of the total of your pills to vitamin 2 and take it twice a day as opposed to 3 times a day. Active disease, you should take it as 3 times a day. And they're even looking now at once a day therapy with these medicines. Because you can imagine, said Pentasa, if you're taking the old form, which is 250 milligrams, you were taking 4 tablets 4 times a day, 16 pills. So anything that can improve that, hopefully is going to improve compliance. And then from the rectal area, you can also supply this mesalamine product through suppositories and enemas. So again, not to belabor this too much, orally, these different types of mesalamine products, they differ from the way that they're delivered. These medicines, sulfasalazine, balsalazide, which is colazole, and this, which was dipentum, have this bond which is broken by the bacteria in the colon, which then provides the active drug to the colon. There are others, such as Lialda, which have a pH or acid-base dependent release. Same with Asacol. And Pentasa is a time release. So if you look at this, the way that these are released, for example, this time release is early, so it actually provides medication to not only the small intestine, the colon, but generally pretty much all of the upper GI and lower GI tract except the stomach, whereas others like Asacol provide active drug to the end of the small intestine and colon, and these that have this bond that's broken up by bacteria is only going to be effective in the colon. So by where these medicines are released, you can choose which may be more effective if you have small bowel disease versus colonic disease. We're going to skip that. This is just a, okay, there, okay. This is a study that was done years ago and was done in ulcerative colitis, but also was true for people with Crohn's disease. And they're looking basically at remission by giving rectal therapy. And they're using hydrocortisone versus the mesalamine, Rawasa enemas, or suppositories. And you can see there's a marked improvement clinically, which was based primarily on bleeding with the use of the mesalamine versus the steroid enemas. And again, this just goes to show you that, again, this is ulcerative colitis, but also can be used in terms of Crohn's colitis, that if you use both oral and rectal therapy or combined therapy, here this is just oral, rectal, combined, oral, rectal, combined. You can see at 1 week, 2 weeks, 3 weeks, the best efficacy in terms of no rectal bleeding was in the combined group. So if someone comes in, they have colonic disease, giving oral as well as rectal will do better than most people just with oral therapy or rectal therapy. This is really a key slide. And this is by Susie Kane, who's from Mayo Clinic, and she looked at compliance. Compliance is a real big key in terms of these diseases, because a lot of the patients we treat are teenagers, adolescents, young adults, and often your patient will come in and you say, "Hi, how you doing? I feel good," and they'll say, "Well, are you taking your medicine?" They say, "Yeah." Well, if you weren't smart enough, you'll say, "Fine," and go on. Well, then you say, "Well, okay, you're taking your medicine." "Well, I'm not taking it every day." And you say, "Well, how many pills you taking?" "Well, I'm supposed to take it 3 times, but I frequently can't remember the middle dose." So it's very important. And what Kane did is she looked at, I think this was based upon insurance claims for medications over a period of a year, and she found that those who were non-adherent, they didn't refill their prescriptions at least 80% of the time, they had a 5 times increased risk of clinical recurrence compared to those who refilled their medicine at least 80% of the time. And this is just not a good, but what this shows you, those who were adherent in taking their medicine stayed in remission, whereas those who did not and were not adherent obviously didn't do as well. And that's not a real brainer, but it's very important. And the problem is, in younger people, even adults, they say, "I feel great." So they stop their medicine. 6 months later, they have a terrible relapse. And sometimes it takes a long time to get that person into remission. And once they've kind of relapsed, sometimes it's tougher to get them back into remission than it was the first time. Not always, but, and this is again the Crohn's and Colitis Foundation, which is one of their studies that they did. I guess we're going pretty far. Well, again, they looked at the reasons for why people, this was a survey of over, I think, 400,000. No, this is a smaller one, about 900 and some non-adherent patients, and they asked them why they didn't take their medicine. And it wasn't so much because there were too many pills. A lot of it was not too many pills per day. What I don't understand is with this slide, they don't actually put the just forgot part. But the actual highest answer was they just forgot. So it's just like anything. Acid reflux, taking your proton pump inhibitor, taking it before you eat. You know, I tell people, put it on your bedside. You know, put a sign on your refrigerator before you go in and start to eat. You got to come up with some routine, because this is a long-term process. This isn't something you're just going to take for a while. Here's old Everett Koop, who used to be, whatchamacallit? Yeah, exactly. And you can see drugs don't work in patients who don't take them. It's pretty obvious. Again, you've got decreased risk of disease progression if you take them. Reduced inflammation, increased healing, decreased risk. Because remember, actually now, active disease is associated long-term with a higher risk of colorectal cancer. And again, patients who continue their maintenance meds are less likely to have flares. I mean, and these are, I'm going to go a little faster now because we still have quite a ways. You know, you're looking at flares, and how do you prevent them? Stress can be associated. You have to learn coping mechanisms. People have lapses in medication, incorrect dosing. Maybe they don't hear what their doctor's telling them. I have people who come back 3 times before it's like they finally understand. I even write it down so they take it home, and they come back as if it's, they didn't really hear what I said. You know, you've got to watch out for the non-steroidals, antibiotics. Make sure what can you do. take your medicines, avoid stress, and there's actually something called a flare symptoms tracker, and this is from the Crohn's colitis slide that you can get on there and follow. Quick thing about steroids, this was back, as you can see, in the 50s, and this was the first real study of use of steroids in inflammatory bowel disease, and it actually was with ulcerative colitis. And the bottom line was those who had active disease, and I'm not going to go into amount of active disease, severity, etc., but in terms of people who were treated with steroids versus those who don't, almost 70% went into remission. Again, if you look at maintenance, not so hot, because it isn't, steroids are not a maintenance medicine. You use it to get a person into remission, but then you got to do something for them after that. So there have been 2 studies that have looked at steroids, and this is from a large cooperative study of Crohn's disease. And the bottom line is, without going through the true details, and you can read this if you like, both showed that steroids were more effective than placebo in inducing remission in Crohn's disease. This actually was a study that looked at, I think, about 180 patients with Crohn's disease and looked at use of steroids short-term, which would be 30 days, and at the end of 1 year. And if you look here, 30 days, this is 30 days, right, almost 60% of patients went into remission, whereas 26% had a partial response and 16% had none. If you look at 1 year, you had initially 58%, only 28% had a prolonged response versus 32% who are now steroid dependent because you can't get them off it, or 38% who ended up going to surgery. So the bottom line is, at the end of a year, you only have 28% of your patients who haven't gone to surgery and are not on steroids. Let's just, oh, the only thing I want to say about here is something called budesonide. Budesonide, also called, why am I blanking? Entocort, this is the brand name, is a type of steroid, but it has a rapid first pass metabolism through the liver. So about 90% of it is metabolized. So that the idea is use of this type of steroid is better long term because you don't have the long-term side effects of the steroids still lingering in your bloodstream. As I said, rapid first pass metabolism, less circulating steroid, fewer long-term effects, superior to placebo, and 5-mesalamine. The bottom line is this drug is now the first choice for treatment of ileal Crohn's disease. So the end of the small bowel, this is, if you have ileal Crohn's alone, this is the drug that you would be put on. Now people talk about steroids, and this is just a little bit about bone mineral density, because anyone who is on steroids 20 milligrams a day for a period of time, chronically on them. I have one patient who came in the other day, a 50-year-old gentleman who has been on steroids 30 to 60 milligrams a day for over a year with symptoms, on azathioprine, and still active disease. So the question is, what happens with time? And people always wonder about steroids and bone density. Well, this is, I'm not going to make this a long haul, but bottom line is, these are people who have never seen steroids, either prednisone, prednisolone, or this new budesonide up here. These are people who have been previously treated with steroids, this dotted line, which are these people here, this one right here, and then these are people who are steroid dependent. They've been on these for long term, they can't get off. And what's surprising is the people who tend to have a marked drop in the bone density are those people who have never seen steroids who are started on steroids. And as you can see, there's a marked drop in the bone density, but it's much less than for budesonide. Whereas those people who are on steroids long-term, or budesonide long-term, they start off with a low bone density, but they really don't drop any further. So the biggest drop in affecting your bones is initial therapy with steroids. And people who are on steroids, budesonide long-term, we get yearly bone densitometries as part of quality of care and monitoring. Steroids, these are just some of the side effects you can get. You can read them for yourself. Again, cataracts, glaucoma. This is a big one. It's called aseptic necrosis of the hip. And I've seen this in people who've been on steroids for a month and those who've been on it for years. And they get these sort of bony infarcts in their hips, sometimes in the knee, and it is like a painful disease. It doesn't go away. You can't do anything except for pain medicines and send them to the best orthopedic doc you can find. But that generally doesn't help. So again, steroids, short term, there's no effect in terms of maintenance. The only deaths, I said, in controlled trials were related to steroids and abscess, which is an infection. And again, recent studies have shown that if you're exposed to steroids, this may alter the course of your disease towards surgery or worse outcomes. So if you have someone who has mild disease, this was done a few years ago, you treat with not so much sulfasalazine anymore, but the mesalamine type products, or you can use sulfasalazine, but often they may become allergic to the sulfa component, then you go on to steroids. Again, if you have disease of the ileum or small intestine, budesonide is the major treatment. Again, if that doesn't work, steroids. That's not the end, of course. Uh-oh. All right, I'm going to whiz fast because we're really getting along here, aren't we? Anyway, the other drugs I've been alluding to, which are, again, part of the step-up. So we've gone antibiotics, which don't do a lot. We've gone to the mesalamine products. We've gone to steroids now. And then the problem is, say you've got someone on steroids, what do you do then? You start tapering them off. They tend to exacerbate. You can't get them off, and they become refractory. So what do you do? So the next step up, sort of the pyramid, are what are called immunologic agents, or immunomodulators. And these are medicines that maybe some of you have heard: Imuran or azathioprine, 6-mercaptopurine, and the other is methotrexate. These are the main three. It kind of depends where in the country you are. We tend to use a lot of azathioprine. New York is like a 6-MP capital. And then, of course, the biologics, which are Humira, Cimzia. Okay, go. So immunomodulators, what do? They basically are agents that weaken or modulate the activity of the immune system, which then decreases the inflammation. When do we use them? We use them in people who are stuck on steroids. We want to get them off. They have been effective, plus minus, in treating perineal disease, not so much abscess and fissures. The other thing is, often we use them as induction agents in people of mild to moderate disease. You know, someone has a first flare, you put them on steroids, as you're tapering them off, you go right to a biologic. To an immunomodulator. Again, people who are refractory to steroids, people like, for example, they're on 30, they get down to 25, they have a flare, they have to go back to 30, they can't get off. We use these medicines. They do have what's called a steroid-sparing effect. The problem is these medicines can take 2 to 6 months to be effective. So you have someone who's really sick, that may not be the best option you have. And the other thing is, we almost always use them now in combination with any of these biologic agents, because they help decrease immunogenicity or antibodies to these biologic agents. You know, these biologic agents, even though some of them are man-made, they're still going to have antibodies. They're not human-made, so to speak. So the problem is, as you develop antibodies to these in your bloodstream, in your body, it makes the drug less effective, because then the drug is binding to the antibody and precipitating out and not being able to bind to the receptor where it's trying to decrease the inflammation. So this is a busy slide, but it kind of looks at 6-MP. Here's azathioprine. There's an enzyme that we measure the effect of that then converts it to 6-MP. So some people use azathioprine, other people use 6-MP. But basically then the active drug is 6-thioguanine, and that's the one that's most effective in the blood in terms of disease activity. The problem is if you have one of these enzymes that's a poor, you call them poor metabolizer, and we always measure this before we start azathioprine. And also you can see this enzyme is also used to break this compound down into another product. If this is missing and it can't convert it there, you're going to have a marked shift this way. And if this level gets really high, then you can have suppression of your white blood cell count. So we always monitor these people in terms of these levels, and also this level, because this level looks at liver toxicity if it gets too high. So this is a fairly simple table, and what it's doing is looking at various levels of the 6-thioguanine in the blood. And basically, as you can see, as the levels get higher, frequency of the response of the active disease gets better. Generally, you want it in this level. The problem is if this level gets too high, as I said, it can affect your white blood cell count. So when you use these medicines, you need to follow various lab studies initially when you're starting. And the big thing I said is starting is people can drop their white blood cell count. So without going into all these details, you really have to monitor blood levels of these and your white blood cell count initially with these medicines. And then toxicity, I said what happens, I said if this enzyme is not effective, it's definitely not working here, so more is being, even though this is less here, more is being pushed here because there's no sort of relief, so to speak, of going up this way to try and decrease the move this way. But on the other hand, if you're measuring this, you always want to measure that too because that can affect your liver. So we measure what are called purine metabolites. So when people are on these medicines, we'll measure the 6-thioguanine and we'll measure the 6-MMP. Come on. And that just, again, just like with the white blood cell count, the 6-MMP measures as the level gets higher, there's a higher risk of toxicity. Main side effects of these medicines, you often can get flu-like reactions initially. You can get liver function abnormalities, and that's one of the concerns when people with inflammatory bowel disease get liver function abnormalities. Is it a side effect of the medication, or is it a side effect of a possible liver problem that can be seen like sclerosing cholangitis? Pancreatitis is something, it's not that frequent, but it's almost classic at 3 weeks when you start this medicine. And generally long-term tolerance is good if you have no real side effects. You can even use this during pregnancy. No risk, well, no evidence of obvious risk of cancer with it. There can be some interactions with this medicine with other medicines that are commonly taken, such as Coumadin. Patients who were taking Bactrim. Allopurinol is a big one because allopurinol inhibits one of these, that product that goes this way, so everything is driven to the right, and that's actually even a classic board question that people are asking in internal medicine and in gastroenterology. Someone who comes in who's on this medicine who was given allopurinol, and you're like, or they're on this medication and their white count is, you know, non-existent, and the answer is because they were on allopurinol for their gout. Okay, and this just looks at the efficacy of, you know, using these immunomodulators like 6-MP. These are people who were not doing well with their disease. They were placed on steroids on a tapering dose, and at the same time one group was started on azathioprine, which is this group, and the other just were put on like a sugar pill. So steroids, tapering, one group was also put on azathioprine, the other was put on a sugar pill. And obviously you can see as you taper off the steroids, those who got nothing, basically those who did well, 7% were in remission at 15 months. You can see initially azathioprine really didn't work any better than the placebo at a month, whoops, come back. But you can see, though, out at 15 months, it's very effective versus placebo. And those people who you're trying to get off of steroids, it actually is much more effective. You guys are going to be so well educated where you're falling asleep. Anyway, one of the biggest risks that people are concerned about with immunomodulators is lymphoma. And if you think about the likelihood of non-Hodgkin's lymphoma, it's about 2 in 10,000 at baseline in inflammatory bowel disease. If they're on immunomodulators, the answer is sort of like a 2-4-6 rule. Baseline 2, if they're on immunomodulators, generally it's 4, and then if you're on both immunomodulators and, this doesn't show it, but basically it's 2-4-6. Here's non-Hodgkin's on anti-TNF without immunomodulators, again about 4 in 10,000. On an immunomodulator, about 4 in 10,000, and on both it's about 6,000. So I'm sorry, 6. So you're talking 2 in 10,000, 4 in 10,000, or 6 in 10,000 with baseline on no meds in Crohn's patients, those on something like azathioprine, and then or on a biologic, come back. Anyway, or a biologic, and if on both, it's about 6 in 10,000. So even though people are concerned about that, you think about 2 in 10,000 people, it's still a very small number, or 6 in 10,000, still a small number. And actually what I didn't show, and I'm probably going to show later, is that further studies have been done in terms of looking at biologic agents and immunomodulators together, and it appears to be more related to the azathioprine immunomodulators. And generally, well, methotrexate, again, I'm not going to go through this. Methotrexate's another immunomodulator agent. It is, at least in this one study by Brian Fagan, who tends to use a lot of methotrexate in his patients. You can look again, this is sort of looking at patients who were steroid dependent, and you can see if they were placed on methotrexate. Initially here at 25 milligrams as an IM shot, and then they were randomized to receive 15 milligrams weekly versus placebo. Marked improvement versus placebo when using methotrexate. Cyclosporin, don't really use it much in inflammatory bowel. We use it in ulcerative colitis, not so much in Crohn's, and I'm going to kind of leave it at that.